Welcome to NCLEX Review Pro, your trusted e-learning platform for focused, high-yield NCLEX preparation. In this session, we're tackling one of the most test-dense topics on the NCLEX-RN, the gastrointestinal problems and related pharmacological interventions. You'll work through carefully selected NGN-style questions
that blend disorders, diagnostics, and pharmacology, each one designed to make you think like a nurse. Across this lesson, we'll cover
all next-gen formats, highlight the text, drop-down close, matrix/grid, ordered response, and high-level select all that applying, each one framed with full rationales and NCLEX alerts.
This lesson will help you connect the why behind the what. Stay focused, take notes, and let's strengthen your GI mastery. Because every question here brings you one step closer to NCLEX success. Let's begin.
Welcome to Section 1, the Gastrointestinal System Disorders Clinical Reasoning Q&A. In this segment, we'll apply clinical reasoning to some of the most high-yield, disorder-based questions on the NCLEX-RN exam. Question 1. Suspected appendicitis, recognizing peritonitis progression. A 27-year-old client was admitted earlier with acute right lower quadrant pain and a provisional diagnosis of appendicitis. Surgery is scheduled later in the morning. 2 hours before the planned procedure, the nurse finds the client restless and pale. The pain, which was once localized, has now spread across the entire abdomen. It has become sharper and more constant. The client reports new nausea followed by repeated vomiting. On inspection, the nurse notices a tense, distended abdomen that appears motionless with each breath. Bowel sounds are faint or absent in all quadrants. On gentle palpation, rebound tenderness is present. Vital signs show a temperature of 38.8 degrees Celsius, a pulse of 118, and a blood pressure of 96/58. The nurse stops the assessment and immediately prepares to notify the surgeon. Pause for a moment and think. Which phrases in this description signal a life-threatening complication? They are pain spreading across the abdomen, sharp, constant pain, nausea and vomiting, a rigid, distended abdomen, absent bowel sounds, rebound tenderness, and vital signs showing fever, tachycardia, and hypotension. All of these findings point to peritonitis, a possible rupture of the appendix. Rationale. These findings show that the appendix has likely perforated, causing inflammation of the peritoneum. This is an emergency. The nurse must notify the surgeon at once, maintain the client NPO, begin 1-5 fluids, and monitor for shock. Do not give pain medicine, reposition, or apply heat. Those actions can mask symptoms or accelerate rupture. NCLEX alert. When pain from appendicitis suddenly becomes generalized, when the abdomen turns rigid and bowel sounds fade, think rupture and peritonitis first. Never apply heat. Never give laxatives. Priority: notify the provider immediately. Key learning focus. This question trains you to recognize danger cues hidden inside a story. It connects vital signs, physical findings, and clinical reasoning, the exact skill measured on the Next Gen NCLEX. Now that you've recognized peritonitis from an appendicitis scenario, let's move to the next question and strengthen your reasoning further. Question 2. Acute pancreatitis, key assessment findings. It is a select all that apply question. A 44-year-old client with gallstones comes in after eating a large fatty meal. Sudden, severe epigastric pain begins. The pain is steady, boring, radiating to the left upper quadrant and to the back. Vomiting does not help. On assessment, there is abdominal guarding and tenderness. Bowel sounds are hypoactive. A faint gray-blue discoloration is seen along the flanks. Serum amylase and lipase levels are elevated. Which findings are consistent with acute pancreatitis? Select all that apply. Option 1. Hyperactive bowel sounds throughout the abdomen. Option 2. Gray-blue discoloration at the flanks. Option 3. Abdominal guarding and tenderness on palpation. Option 4. Severe left upper quadrant pain radiating to the back. Option 5. Black, tarry stools, also called melena. Option 6. Passage of frequent loose stools or diarrhea. Correct responses are Option 2, Option 3, and Option 4. Let's look at the rationale. Option 2. Gray-blue discoloration at the flanks is known as Turner's sign. It indicates enzyme leakage and subcutaneous bleeding, a hallmark of severe pancreatitis. Option 3. Abdominal guarding and tenderness show peritoneal irritation from inflammation. This is a classic acute finding. Option 4. Left upper quadrant pain radiating to the back, that steady, boring pain, is the signature symptom of pancreatitis. It often worsens after meals or when lying flat. Incorrect findings. Hyperactive bowel sounds are not expected. Inflammation usually causes an ileus, so bowel sounds are decreased or absent. Black, tarry stools point to an upper GI bleed, not pancreatitis. Frequent diarrhea is uncommon. GI motility decreases and the client is kept NPO. NCLEX alert. Remember, Cullen's sign at the umbilicus and Turner's sign at the flanks both indicate internal bleeding in pancreatitis. Priority actions. Keep the client NPO, start aggressive IV fluids, manage pain with IV opioids, and monitor for hypovolemia or respiratory distress. Key takeaway. Recognize the pancreatitis triad: left upper quadrant or epigastric pain radiating to the back, abdominal guarding with decreased bowel sounds, and gray-blue flank discoloration. When you see that pattern, think acute pancreatitis first. Let's continue to the next question. Question 3. Acute cholecystitis, recognizing key manifestations. A 50-year-old client presents after eating fried food. They report nausea, belching, and indigestion. Temperature is 38.3 degrees Celsius. Mild tachycardia is present, and there is sharp right upper quadrant pain radiating to the right scapula. Pain began about 1 hour after the meal. On exam, the right upper quadrant is tender and Murphy's sign is positive. Which assessment findings support acute cholecystitis? Select all that apply. Option 1, fever. Option 2, positive Cullen's sign. Option 3, complaints of indigestion. Option 4, palpable mass in the left upper quadrant. Option 5, pain in the upper right quadrant after a fatty meal. Option 6, vague lower right quadrant abdominal discomfort. Correct responses: Option 1, Option 3, and Option 5. Let's see. Rationale behind correct options. Fever supports inflammation of the gallbladder. Low-grade fever is common. Indigestion, dyspepsia, nausea, and gas occur because bile flow is obstructed and fat digestion is impaired. Postprandial right upper quadrant pain radiating to the right scapula is the hallmark of cholecystitis, especially after fatty meals. Why the others are not selected? Option 2, Cullen's sign indicates hemorrhagic pancreatitis, not cholecystitis. Option 4, left upper quadrant relates to the spleen or stomach. The gallbladder is in the right upper quadrant. Option 6. Lower right quadrant discomfort suggests appendicitis, not gallbladder disease. NCLEX alert. Right upper quadrant or epigastric pain, worse after fatty meals, with a positive Murphy's sign. Think cholecystitis. Priority steps. Keep the client NPO. Start IV fluids. Give antiemetics and analgesics, and prepare for possible cholecystectomy. Let's look at key takeaway. Use pain location and meal relationship to separate cholecystitis from pancreatitis and appendicitis. You recognized the classic gallbladder pattern. Let's move to the next question. Question 4. Viral hepatitis, promoting adequate nutrition. MCQ type. A 38-year-old client is recovering from acute viral hepatitis. They tell the nurse, "I have no appetite and food tastes awful lately." The client appears fatigued and feels nauseated when smelling fried food. Which instruction should the nurse give to promote adequate nutrition? Option 1. Select foods high in fat to increase caloric intake. Option 2. Increase fluid intake, including nutritious juices. Option 3. Eat a large evening meal when appetite improves at night. Option 4. Eat only 3 large meals daily to avoid frequent nausea. The correct answer is option 2. Increase fluid intake, including nutritious juices. Rationale. Option 2 is correct because clients with hepatitis often tolerate fluids and juices better than solid meals. Aiming for 2,500 to 3,000 milliliters per day supports liver recovery, helps flush toxins, and prevents dehydration. Light fluids and fruit juices also provide calories and vitamins when heavier foods are unappealing. Now, why the others are incorrect? Option 1. Foods high in fat worsen nausea and are poorly tolerated because bile production is decreased. The diet should be low in fat and high in carbohydrates. Option 3. Appetite is usually better in the morning, not at night. Encourage a light, nutritious breakfast. Option 4. Eating small, frequent meals is much better than 3 large ones. It reduces nausea and prevents fatigue. NCLEX alert. Encourage small, frequent, low-fat meals with plenty of fluids and rest periods. Avoid alcohol and any hepatotoxic medications. Schedule the main meal earlier in the day when appetite is best. Some key takeaways. Hydration, gentle nutrition, and energy conservation are the foundation of care for viral hepatitis. Think: fluids before food and light meals before large ones. You've covered liver nutrition. Now let's move to the next question and apply more reasoning on disease-specific cues. Question 5. Hepatitis A. Expected assessment findings. A 32-year-old client reports eating raw oysters at a festival 2 weeks ago. Now they feel tired all the time and cannot tolerate the smell of food. The provider confirms acute hepatitis A. Which assessment finding should the nurse expect? Option 1. Malaise. Option 2. Dark, tarry stools. Option 3. Weight gain. Option 4. Left upper quadrant discomfort. The correct answer is option 1. Malaise. Let's look at the reasoning behind that choice. Malaise is a generalized feeling of weakness, tiredness, or low energy. Clients with acute hepatitis almost always describe this early in the disease. It appears in the prodromal or pre-icteric phase, even before jaundice occurs. So when a client with hepatitis says, "I feel worn out," that is completely expected. Now let's break down why the other options don't fit this condition. Option 2, dark tarry stools indicate an upper GI bleed. Hepatitis A actually causes pale or clay-colored stools because bile doesn't reach the intestine. Option 3. Weight gain is not typical. These clients often lose weight because nausea and loss of appetite reduce intake. Option 4. Left upper quadrant pain doesn't match. The liver is in the right upper quadrant, so that's where tenderness would appear. Here are a few NCLEX alerts you want to remember. Hepatitis A spreads through the fecal-oral route, often from contaminated food or water. Teach strict hand hygiene. Watch for jaundice, dark urine, and clay-colored stools as bilirubin backs up. And make sure clients avoid alcohol and any hepatotoxic medications while the liver heals. And here's the key takeaway from this question. When a hepatitis A client reports profound tiredness, low appetite, or a general sense of not feeling well, recognize that as malaise, an expected, early sign of viral hepatitis. It helps you differentiate normal disease progression from dangerous complications. Understanding these subtle cues strengthens your clinical judgment and helps you answer similar questions on the NCLEX with confidence. Let's move on to the next question. Question 6. Post-Hemorrhoidectomy Safe Nursing Interventions. Item type: select all that apply. A client has just returned to the surgical unit after a hemorrhoidectomy. As the nurse, your goals are simple but critical. Promote comfort, prevent bleeding, and support soft, easy bowel movements during recovery. Which nursing interventions are appropriate for this client? Select all that apply. Option 1. Administer stool softeners as prescribed. Option 2. Instruct the client to limit fluid intake to avoid urinary retention. Option 3. Encourage a high-fiber diet to promote bowel movements without straining. Option 4. Apply cold packs to the anal rectal area over the dressing until the packing is removed. Option 5. Help the client to a Fowler's position to place pressure on the rectal area and decrease bleeding. The correct answers are Option 1, Option 3, and Option 4. Rational. Option 1. Administering stool softeners is essential. After a hemorrhoidectomy, we want bowel movements to be soft and easy to pass so the client does not strain, tear the suture line, or trigger bleeding. Medications like Docusate or polyethylene glycol help prevent constipation and protect the surgical site. Option 3. Encouraging a high-fiber diet along with good fluid intake also supports soft, regular stools. Fiber pulls water into the stool and prevents hard, painful defecation. This reduces anxiety about the first bowel movement and lowers the risk of complications. Option 4. Cold packs applied to the anal rectal area in the first 24 hours help reduce swelling, pain, and bleeding. Later, once packing is removed and the surgeon approves, care often transitions to warm sitz baths to promote circulation and comfort. Now let's see why the remaining options are not appropriate. Option 2. Limiting fluid intake is unsafe here. We actually want to increase fluids to keep stools soft. Restricting fluids leads to constipation, hard stools, and more straining. Exactly what we are trying to avoid. Option 5. Placing the client in Fowler's position to place pressure on the rectal area is also incorrect. High Fowler's increases venous pressure in the rectal area and can promote bleeding, not reduce it. Side lying or a more neutral position is preferred to reduce strain on the operative site. Now, let's highlight a few NCLEX-style alerts from this scenario. After anorectal surgery, The top priorities are pain control and bleeding prevention. Avoid rectal temperatures, enemas, or suppositories until the surgeon specifically allows them. Encourage fluids, fiber, and stool softeners so the client can pass stool without trauma. And remember, use cold packs first, then progress to warm sitz baths after about 24 hours for ongoing comfort. Here's the key takeaway from this question. Every intervention after a hemorrhoidectomy should answer one of three goals. Does it prevent strain? Does it protect the surgical site and reduce bleeding? Does it promote gentle, comfortable bowel movements? If the answer is no, it probably doesn't belong in the care plan. When you practice thinking this way, you're not just memorizing. You're applying safety and risk reduction, exactly how the NCLEX wants you to think. Let's move on to the next question. Question 7. GERD. Substances that worsen reflux. The nurse is reinforcing dietary teaching for a client who has just been diagnosed with gastroesophageal reflux disease, or GERD. The client says, "I'm not sure which foods make my heartburn worse." Which food items should the nurse instruct the client to avoid? Select all that apply. Option 1. Coffee. Option 2. Chocolate. Option 3. Peppermint. Option 4. Non-fat milk. Option 5. Fried chicken. Option 6. Scrambled eggs. The correct answers are option 1, option 2, option 3, and option 5. Let's look at the reasoning behind these correct choices. Coffee, whether caffeinated or decaf, can irritate the esophagus and relax the lower esophageal sphincter, or LES. A relaxed sphincter allows acid to move up into the esophagus more easily, triggering heartburn. Chocolate contains methylxanthines, which also decrease LES tone. That means more reflux and more burning. Even though peppermint sometimes helps with other types of stomach upset, for GERD, it actually relaxes smooth muscle, including the sphincter. That relaxation makes symptoms worse. Option 5. Fried chicken. High-fat, fried foods delay gastric emptying and increase pressure in the stomach and lower esophagus. That extra pressure pushes acid up, worsening reflux. Now let's see why the remaining options are not chosen. Option 4. Non-fat milk. Skim or low-fat milk can temporarily neutralize acid and is less likely to aggravate reflux compared with whole milk or cream-based products. It's usually acceptable in moderation. Option 6. Scrambled eggs. When prepared without excess butter or oil, eggs provide protein and relatively low fat. They do not significantly lower LES pressure and can be part of a GERD-friendly diet. Now, let's pull out a few NCLEX-style alerts from this topic. For GERD, remember the main trigger foods that relax the lower esophageal sphincter: caffeine, chocolate, peppermint, fatty or fried foods, carbonated drinks, and alcohol. In addition to avoiding these, teach clients to eat small, frequent meals, stay upright after eating, and avoid lying down or exercising for 2 to 3 hours after a meal. At night, raising the head of the bed about 6 to 8 inches can significantly reduce reflux episodes. Here's the key takeaway from this question. When you hear GERD, think LES pressure. Anything that relaxes the sphincter or increases stomach pressure will worsen reflux. If you can connect the food to that mechanism, you can predict whether it belongs on the avoid list. Let's move on to the next question and keep building your GI clinical judgment. Question 8. Peptic ulcer disease. Recognizing perforation. A 54-year-old client with a long history of peptic ulcer disease is admitted with persistent epigastric discomfort. Earlier in the shift, the client was still eating small amounts of broth and reported only mild heartburn relieved by antacids. But 2 hours later, everything changes. The client suddenly clutches the abdomen and says, "It feels like something just tore inside me." They appear pale, restless, and diaphoretic. Any movement increases the pain. On assessment, the abdomen is distended and rigid, and even light palpation causes sharp, intolerable pain. Vital signs show a blood pressure of 92/56, a pulse of 118, and respirations of 28 per minute. Bowel sounds are absent in all quadrants. Temperature is 38.3 Celsius. A nasogastric tube continues to drain small amounts of clear fluid, and the urine output over the past hour is 20 milliliters. Earlier, the client had no dizziness on standing and denied chest pain or shortness of breath. Your task: highlight the words or phrases that indicate the ulcer has perforated. The key phrases are, "It feels like something just tore inside me." "Abdomen is distended and rigid." "Any motion increases the pain." "Sharp, intolerable pain." Blood pressure 92/56, pulse 118. Bowel sounds absent in all quadrants. Urine output 20 milliliters. Let's look at the reasoning behind these selections. A sudden, tearing pain is a classic description of an ulcer perforation. A rigid, board-like abdomen with absent bowel sounds signals severe peritoneal irritation and paralytic ileus. Hypotension, tachycardia, and very low urine output show the early stages of hypovolemic shock as fluid shifts into the abdomen. Together, these findings point to a surgical emergency. Now let's look at why the other statements do not matter here. Eating broth, mild heartburn, clear NG drainage, and normal standing tolerance were part of the earlier, stable picture. They don't help us identify the crisis. This question tests whether you can separate stable background information from critical, life-threatening cues. NCLEX alert. A rigid, distended abdomen, sudden tearing pain, and shock signs like hypotension and tachycardia. That combination equals perforation with peritonitis, and it requires immediate surgery. Priority actions include keeping the client NPO, starting 1-5 fluids, notifying the surgeon at once, and monitoring for shock. Do not give pain meds or antacids, and do not irrigate the NG tube unless the provider specifically orders it. These are high-stakes situations, and the NCLEX wants you to identify the danger cues without hesitation. Here's the key takeaway from this question. A board-like abdomen plus sudden, severe pain is one of the most important red flag findings in GI disorders. When you see it, think ulcer perforation, think peritonitis, and think surgical emergency. Every time. Let's go on to the next question and keep sharpening your cue recognition skills. Question 9. Acute pancreatitis. Priority nursing interventions. A client is admitted with severe acute pancreatitis. They have intense upper abdominal pain that radiates to the back, with nausea and vomiting. The provider has written new orders, and the nurse plans care with 3 major goals: to rest the pancreas, to control the pain, and to prevent complications. Which nursing interventions would the nurse expect to be prescribed? Select all that apply. Option 1. Maintain NPO, nothing by mouth status. Option 2. Encourage coughing and deep breathing. Option 3. Give small, frequent, high-calorie feedings. Option 4. Maintain the client in a flat, supine position. Option 5. Administer hydromorphone intravenously as prescribed for pain. Option 6. Maintain IV fluids at 10 milliliters per hour to keep the vein open. The correct answers are option 1, option 2, and option 5. Let's look at the reasoning behind these correct choices. Keeping the client NPO rests the gastrointestinal tract and suppresses pancreatic enzyme secretion. If the client eats, the pancreas is stimulated to release enzymes that will further autodigest pancreatic tissue. During the acute phase, nutrition and hydration are supported by IV fluids, and later, carefully reintroduced enteral feeding. Option 2. Encourage coughing and deep breathing. Clients with severe abdominal pain tend to take shallow breaths, which increases the risk of atelectasis and pneumonia. Turning, coughing, deep breathing, and incentive spirometry promote lung expansion and help prevent respiratory complications. Option 5. Administer hydromorphone IV as prescribed. Pain control is a top priority in acute pancreatitis. Severe pain increases stress and can stimulate more pancreatic secretion. IV opioids, such as hydromorphone, provide effective pain relief and help stabilize the client's overall status. Now let's see why the other options are not appropriate in the acute phase. Giving small, frequent, high-calorie feedings is incorrect right now. In the acute phase, we do not give oral intake. Feeding is reintroduced only after the pain improves and amylase and lipase levels start to trend down. Maintaining a supine position is also incorrect. Lying flat typically worsens abdominal pain and increases pressure. Many clients with pancreatitis feel better in a side-lying position with the head elevated or with knees drawn up toward the chest. Keeping IV fluids at 10 milliliters per hour is not enough. This is just a keep vein open rate. Clients with acute pancreatitis often need aggressive IV hydration, sometimes in the range of 250 to 500 milliliters per hour initially, to prevent hypovolemia, third spacing, and shock. Now let's pull out a few NCLEX-style alerts from this scenario. In the acute phase of pancreatitis, think of a core bundle: NPO status, possible NG suction if ordered, aggressive IV fluids, and strong pain control. You should also monitor closely for hypovolemia, for respiratory distress, and for signs of infection or organ failure. Morphine may cause spasm of the sphincter of Oddi, so hydromorphone is often preferred. Here's the key takeaway from this question. Your priorities in acute pancreatitis are to rest the pancreas, control the pain, and protect the lungs and circulation. If an intervention stimulates digestion, increases pain, or starves the circulation of fluids, it probably does not belong in the acute care plan. Let's move on to the next question and keep building that level of thinking. Question 10. Crohn's disease flare-up. Identifying faulty dietary teaching item type. Highlight the text blueprint. Area: health promotion and maintenance, self-care, nutrition. The nurse is reviewing discharge instructions with a client who has Crohn's disease and is recovering from a mild flare. The client says they'd been reading about diet changes and want to make sure they're doing things correctly. During the teaching session, the client makes several statements. I know this condition can come and go, with flare-ups and remissions. I'm going to start practicing relaxation breathing and yoga to help with stress. I'll stay away from coffee and energy drinks because caffeine irritates my stomach. I plan to increase the fiber in my diet so my bowels move more regularly. I'll try to eat foods that are high in calories and protein since I've lost some weight. Your task is to highlight the one statement that indicates the client needs further teaching. The incorrect statement is, I plan to increase the fiber in my diet so my bowels move more regularly. Let's look at the reasoning behind this choice. During a Crohn's disease flare, the bowel is inflamed and the mucosa is extremely sensitive. High-fiber foods, such as raw vegetables, whole grains, nuts, and salads, increase bowel motility and can trigger more diarrhea, more cramping, and more irritation. So during an exacerbation, the recommended diet is low-fiber, high-calorie, high-protein, and easy to digest. Fiber is reintroduced cautiously during remission, not during a flare. Now let's take a moment to look at why the other statements are correct. Understanding that Crohn's has cycles of remission and relapse is accurate. Practicing relaxation techniques like yoga or breathing exercises helps reduce stress-induced flares. Avoiding caffeine is appropriate because caffeine stimulates the GI tract and can worsen symptoms. And increasing calories and protein supports nutritional recovery and prevents weight loss. Here are a few key NCLEX alerts to remember. During a flare-up, think low residue diet, low fiber, low roughage, minimal bowel stimulation. Encourage fluids, vitamin supplementation, and electrolyte replacement to prevent dehydration. Avoid alcohol, caffeine, nicotine, and raw roughage until inflammation settles. The NCLEX often tests this by giving you one incorrect self-care statement mixed in with several correct ones. And here's the key takeaway from this question. When Crohn's disease is active, the bowel needs rest, not stimulation. So if you hear a client say they plan to increase fiber during a flare, that's your clue to step in and correct the teaching. Understanding the difference between flare phase care and remission phase care is essential for strong clinical judgment. Let's continue to the next question and keep building that reasoning skill. Question 11. Assessing for asterixis. The nurse is reviewing the chart of a client with advanced liver cirrhosis and sees a note from the provider. Assess for asterixis. The nurse understands this is an early sign of hepatic encephalopathy caused by rising ammonia levels. Which action should the nurse take to assess for asterixis? Option 1. Dorsiflex the client's foot. Option 2. Measure the abdominal girth. Option 3. Ask the client to extend the arms forward, palms down, wrists dorsiflexed, and fingers spread. Option 4. Instruct the client to lean forward at the waist. The correct answer is option 3. Ask the client to extend the arms forward, palms down, wrists dorsiflexed, and fingers spread. Let's look at the reasoning behind that choice. To assess for asterixis, the nurse has the client hold both arms straight out in front, with palms facing down, wrists bent back, and fingers spread apart. After a few seconds, if asterixis is present, the hands will show irregular flapping or jerking movements, almost like a bird flapping its wings. This flapping tremor is a classic sign of metabolic encephalopathy from high ammonia levels in severe liver disease. So this exact position of the arms, wrists, and fingers is the key to correctly assessing for asterixis. Now let's see why the other options are not correct. Dorsiflexing the foot is more related to checking for clonus or other reflex changes, not for asterixis. Measuring abdominal girth is useful for monitoring ascites, but it tells you nothing about neurological status. Asking the client to lean forward at the waist might be part of a cardiac or pulmonary assessment, such as in pericarditis or orthopnea, but it does not assess for asterixis. Here are a few NCLEX alerts connected to this question. Asterixis is one of the earliest and most reliable signs of hepatic encephalopathy. It is often accompanied by confusion, sleep pattern changes, and lab evidence of elevated ammonia levels. Treatment focuses on lowering ammonia with medications like lactulose or rifaximin, managing protein intake, and addressing any triggers such as GI bleeding or infection. And here's the key takeaway. Whenever you see advanced cirrhosis with concerns about mental status, think Asterixis as a critical assessment. If the hands flap when the arms are extended, you should immediately connect that finding to worsening liver failure and possible encephalopathy. Being able to match the right physical exam maneuver to the right complication is a powerful clinical skill. Let's move on to the next question and keep building your assessment to pathophysiology reasoning. Question 12. Cirrhosis. Diet and ammonia control. Item type, matrix grid. Blueprint. Area, physiological integrity, physiological adaptation, liver disorders. A client with advanced hepatic cirrhosis has an ammonia level of 85, which is above the normal range. The nurse is teaching how to choose foods that help reduce ammonia production while still providing enough energy and nutrition. For each of the following foods, decide if it should be preferred or avoided until ammonia levels stabilize. Here are the food items: baked potato with steamed vegetables, grilled chicken breast, plain white rice with fruit compote, cheeseburger with fries, vegetable soup with toast, tuna salad sandwich. The correct pattern is preferred, baked potato with steamed vegetables, plain white rice with fruit compote, vegetable soup with toast. Avoid, grilled chicken breast, cheeseburger with fries, tuna salad sandwich. Let's look at the reasoning behind the preferred foods first. The baked potato with steamed vegetables is low in protein and high in complex carbohydrates. It provides steady energy without adding much nitrogen load, so it does not significantly increase ammonia production. Plain white rice with fruit compote is another gentle, easily digested, carbohydrate-rich option. Again, mostly carbs, very little protein, a good choice when ammonia levels are high. Vegetable soup with toast is light, hydrating, and low in animal protein. It can provide vitamins, fluids, and calories while keeping protein intake temporarily restricted. Now let's see why the other foods should be avoided for now. Grilled chicken breast is a lean source of protein, but it is still animal protein, and protein breakdown generates nitrogen, which is converted into ammonia. With cirrhosis and high ammonia, that extra protein load makes encephalopathy worse. A cheeseburger with fries adds a double burden: high protein from the meat and cheese, and high saturated fat. This combination is very taxing on a damaged liver. The tuna salad sandwich also provides significant animal protein and extra fat from mayonnaise. Again, that means more nitrogenous waste for the liver to handle, which can worsen confusion and other signs of hepatic encephalopathy. Now let's pull out a few NCLEX-style alerts from this topic. When ammonia levels are elevated, the short-term goal is to temporarily restrict protein and emphasize carbohydrate-based meals that are easier on the liver. Medications such as lactulose and rifaximin are used to remove ammonia through the gastrointestinal tract. Once the client begins to stabilize, small amounts of plant or dairy protein can be reintroduced carefully, such as yogurt, lentils, or soft cheese, depending on provider orders. This kind of question links lab values, diet planning, and prevention of neurologic decline, all in one step. That's exactly how the NCLEX tests higher-level reasoning. Here's the key takeaway. In a hepatic crisis with high ammonia, think carbs now, protein later. Choose simple, low-protein meals like potatoes, rice, vegetables, and light soups. Avoid heavy animal protein and high-fat fast foods until ammonia comes back under control. When you can look at a tray of food and instantly tell which items protect the liver and which ones strain it, you're thinking like a safe, exam-ready nurse. Let's move on to the next question and keep practicing that level of integrated judgment. Question 13. Duodenal versus gastric ulcer. Pain pattern recognition. The nurse is assessing a client with a long history of peptic ulcer disease. The client reports recurring episodes of upper abdominal pain that come and go in relation to meals. The nurse wants to decide whether this pattern sounds more like a duodenal ulcer or a gastric ulcer. You will complete 2 statements by choosing the most accurate option for each blank. First statement. In a client with a duodenal ulcer, pain typically begins. Choices for the blank one are soon after eating, 2 to 4 hours after meals, immediately on awakening, or randomly during the day. The correct choice is 2 to 4 hours after meals. Second statement. This type of pain is usually, choices for the blank 2 are relieved by food or antacids, worsened by eating, unaffected by dietary intake, or associated only with stress. The correct choice is relieved by food or antacids. Let's look at the reasoning behind these answers. For a duodenal ulcer, the classic pattern is the client feels better while food is in the stomach, and pain starts after the stomach empties, usually 2 to 4 hours after a meal, or even in the middle of the night. Food and antacids act like a buffer, so eating or taking an antacid temporarily relieves the pain. That's why we often summarize duodenal ulcers with the pattern, pain comes later, food brings relief. Now, let's contrast that with a gastric ulcer to make the difference clear. With a gastric ulcer, food stimulates acid in an already irritated stomach, so pain tends to occur soon after eating, and eating actually worsens the discomfort. Clients may begin to avoid food to prevent pain, which can lead to weight loss. You can remember this as food causes pain in gastric ulcers, but food relieves pain in duodenal ulcers. Here are a few NCLEX alerts related to this topic. For both types of ulcers, monitor for signs of GI bleeding, such as black, tarry stools or coffee ground emesis. Any sudden change to severe, constant pain with a rigid abdomen should make you think about perforation, which is a surgical emergency. And here's the key takeaway. When you see a question about ulcer pain and timing, focus on when the pain starts in relation to food, and whether food helps or hurts. Pain, then food, then relief, that's duodenal. Food, then pain, then avoidance, that's gastric. Being able to decode that simple pattern will help you answer many ulcer questions correctly on the NCLEX. Great job working through Section 1. Now we're going to shift into Section 2, Procedures and Diagnostics, Nursing Priorities for GI Disorders. In this next group of questions, we'll focus on what the nurse must do before, during, and after key diagnostic procedures. We'll look at things like endoscopy care, ERCP prep, NG tube safety, T-tube monitoring, which post-surgical priorities, and recognizing which provider orders must be questioned. This is where the NCLEX expects you to think like a safety-first nurse, to know what is appropriate, what is dangerous, and what requires immediate intervention. So take a breath, reset your focus, and let's move into Procedures and Diagnostics, questions 14 through 24. Now let's move into question 14, an ordered response item focused on post-procedure safety after an EGD. A client has just returned from the endoscopy suite after an esophagogastroduodenoscopy, or EGD, done under moderate sedation to evaluate a suspected duodenal ulcer. As the nurse, your goal in the recovery phase is to protect the airway, monitor for sedation effects, and watch for early complications. You are given several nursing actions and asked to place them in the correct order. Here are the options. Option A. Position the client in a side-lying position to maintain airway patency and prevent aspiration. Option B. Assess for the return of the gag reflex before offering fluids or food. Option C. Monitor vital signs and oxygen saturation as the client awakens from sedation. Option D. Begin oral fluids when the gag reflex has fully returned and the client is alert. Option E. Observe for potential complications such as abdominal pain, bleeding, or rising temperature. Take a moment and think. What should you do first, and how would you sequence the rest? The correct order is A, C, B, D, E. Let's walk through why this is the correct sequence. Step A. Position the client in a side-lying position. This is done first to maintain a patent airway and reduce the risk of aspiration while the client is still sedated and the gag reflex is depressed. Airway protection always comes before anything involving the mouth or fluids. Step C. Monitor vital signs and oxygen saturation. As the client begins to wake up, you want to detect hypoventilation, hypotension, or hypoxia early. Sedation can depress breathing and circulation, so continuous monitoring is critical at this stage. Step B. Assess for the return of the gag reflex. Before you offer anything by mouth, you must confirm that the client can swallow and protect their own airway. You might do this by gently touching the back of the throat as ordered, or having them sip a very small amount of water under close observation. Step D. Begin oral fluids. Once the gag reflex has fully returned and the client is alert, you can start with small sips of water and then progress as tolerated. This confirms safe swallowing and starts to reintroduce oral intake. Step E. Observe for potential complications. Finally, you continue monitoring for signs of perforation or bleeding, such as severe abdominal pain, chest pain, tachycardia, or fever. This is an ongoing responsibility throughout the rest of the post-procedure period. Now, let's connect this to how the NCLEX thinks about priorities. After any sedated procedure, your mental checklist should be airway first, then vital signs, then swallowing safety, then fluids, then complication surveillance. If a question ever tempts you to offer food or drink before checking the gag reflex, that is almost always a trap. Key takeaway. For post-EGD care, never rush to feed. Protect the airway, monitor recovery from sedation, then restore oral intake safely, and always keep an eye out for perforation or bleeding. When you consistently think in that sequence, you're using safety and risk reduction exactly the way the NCLEX wants. Now we're ready to move on to the next question. Question 15. ERCP Teaching Errors. Identifying incorrect client statement. Item type, highlight the text. The nurse is preparing a client for an ERCP, an endoscopic retrograde cholangiopancreatography, to evaluate possible gallbladder and bile duct disease. After the teaching session, the client repeats back what they've understood about the procedure and says, "I understand that I'll need to sign a consent form before the test. They said I'll receive IV medication to help me relax during the procedure. I'm glad they'll use a throat numbing spray so I don't gag when the scope goes in. I'm relieved I won't have to lie still for the whole procedure. I move around a lot when I'm nervous. They told me the procedure could take about an hour and that I might have a sore throat afterward." Your task is to highlight the one statement that shows the client needs further teaching. Take a second and think. Which sentence sounds unsafe or inaccurate for an ERCP? The statement that needs correction is, "I'm relieved I won't have to lie still for the whole procedure. I move around a lot when I'm nervous." Let's look at the reasoning behind that. During an ERCP, a flexible scope is passed through the throat, down the esophagus, and into the stomach and duodenum to access the bile ducts. The client must lie still the entire time. Movement during the procedure could cause the scope to injure or perforate the esophagus, stomach, or duodenum, or trigger bleeding. Sedation and throat numbing spray are used specifically to help the client relax and remain still, not to allow movement. Now let's quickly review why the other statements show correct understanding. Saying, "I'll need to sign a consent form" is correct. ERCP is an invasive procedure, and informed consent is required. Saying, "I'll receive IV medication to help me relax" is also correct. Moderate sedation is typically used during the test. "I'm glad they'll use a throat numbing spray so I don't gag." This is true as well. A local anesthetic spray helps reduce gagging when the scope is passed. And the procedure could take about an hour and I might have a sore throat afterward. That's accurate too. Mild sore throat is a common and expected effect after an ERCP. So the only problematic statement is the one about not needing to lie still. Here are some NCLEX-style alerts from this topic. Before an ERCP, the nurse should verify informed consent, ensure the client has been NPO for 6 to 8 hours, and remove any dentures or oral prosthetics. After the procedure, keep the client NPO until the gag reflex returns, then gradually reintroduce fluids. Monitor closely for signs of perforation or pancreatitis, such as increasing abdominal pain, fever, tachycardia, or bleeding. And here's the key takeaway from this question. For endoscopic procedures like ERCP, client teaching must emphasize staying still, airway protection, and post-procedure monitoring for complications. If a client believes they can move around during the procedure, that's a big red flag and a teaching priority. Questions like this on the NCLEX test whether you can pick out one unsafe statement hidden among several correct ones, a core clinical judgment skill. Let's move on to the next question and keep sharpening your procedure safety reasoning. Question 16. Hepatitis A, transmission and exposure. Recognition, item type, drop-down close. The nurse is interviewing a client who has recently been diagnosed with hepatitis A. The client reports fatigue, jaundice, and mild abdominal discomfort. As part of the history and teaching, the nurse wants to clarify how hepatitis A is spread and what common exposures might have caused it. You will complete 2 statements by choosing the best option for each blank. First statement. Hepatitis A is most commonly transmitted through the drop-down choices are blood-borne route, fecal-oral route, airborne droplets, sexual contact route. The correct choice is fecal-oral route. Second statement. Clients often become infected after drop-down choices are eating raw or undercooked shellfish, receiving a blood transfusion, sharing contaminated needles, engaging in unprotected sex. The correct choice is eating raw or undercooked shellfish. Let's look at the reasoning behind these answers. Hepatitis A spreads when a person ingests food or water contaminated with stool from someone who is infected. This is called the fecal-oral route. Think about poor hand hygiene, contaminated water, or food prepared by someone who didn't wash their hands properly. Raw or undercooked shellfish, especially from polluted waters, are a classic source of hepatitis A infection. Shellfish can concentrate viruses and bacteria from contaminated water, and if they're eaten raw, the virus goes straight into the GI tract. Now let's quickly examine why the other options do not fit hepatitis A. Receiving a blood transfusion, sharing contaminated needles, and unprotected sex are more typical for hepatitis B and hepatitis C, which are bloodborne or body fluid-borne infections. Airborne droplets also don't apply. Hepatitis A is not spread by coughing or sneezing. So for hepatitis A, the pattern you should lock in is fecal-oral transmission plus contaminated food or water, especially shellfish. Here are some NCLEX-style alerts linked to this topic. Prevention starts with strict hand hygiene after using the bathroom and before handling food. Clients should avoid raw shellfish and make sure they drink from safe water sources. Vaccination is recommended for food handlers, travelers to endemic regions, and healthcare workers at risk of exposure. In outbreaks, standard plus contact precautions may be used when there is fecal incontinence or poor hygiene. And here's the key takeaway from this question. When you see hepatitis A on an exam, you should immediately think fecal-oral spread, poor sanitation, contaminated food or water, and raw shellfish. Differentiating hepatitis A from bloodborne types like B and C is a high-yield skill, both for safe practice and for scoring points on the NCLEX. Keep that transmission pattern in mind as we move forward to the next question. Question 17. Post-Cholecystectomy, T-tube drain assessment and nursing response. It's a matrix grid type question. A client is 24 hours post-open cholecystectomy with a T-tube in place for bile drainage. The nurse is checking the drainage color, amount, and consistency, and must decide what is expected, what requires a nursing adjustment, and what needs immediate provider notification. You will classify each finding into one of three categories: expected, document only, requires nursing intervention, or notify the healthcare provider. Here are the T-tube findings. 750 milliliters of green-brown drainage during the first 24 hours post-op. Sudden cessation of drainage. Tubing appears kinked. Drainage becomes bright red and the client reports increasing abdominal pain. Drainage exceeds 1,000 milliliters per day for 2 consecutive days. The client accidentally raises the drainage bag above the level of the abdomen. Serosanguineous drainage transitions to clear golden bile by day 3. Take a moment and think about how you would classify each one. Let's go through them one by one. Finding 1. 750 milliliters of green-brown drainage in the first 24 hours. This is expected, document only. Typical T-tube output in the first day is around 500 to 1,000 milliliters of dark green or brown bile. We still record the amount, color, and time, but no extra action is needed. Finding 2. Sudden cessation of drainage, tubing appears kinked. This requires nursing intervention. A sudden stop in drainage may be due to a simple issue like a kinked or dependent loop in the tubing. The nurse should reposition the tubing, remove the kink, and reassess. If drainage still doesn't resume, then it may require escalation. Finding 3. Drainage becomes bright red with increasing abdominal pain. This requires you to notify the healthcare provider immediately. Bright red drainage suggests active bleeding, and when it's combined with new or worsening abdominal pain, it could indicate a hemorrhage or bile leak. This is not expected and must be reported. Finding 4. Drainage exceeds 1,000 milliliters per day for 2 consecutive days. This also means notify the healthcare provider. More than a liter of bile daily for 2 days is excessive. It raises concern for ongoing leak, fluid and electrolyte imbalances, and potential complications. Finding 5. The client accidentally raises the drainage bag above the abdomen. This requires nursing intervention. The bag must be kept below the level of the abdomen so that bile drains out by gravity. When the bag is raised above the abdomen, bile can flow backward into the biliary system, increasing the risk of infection or pressure injury. The nurse needs to reposition the bag and re-educate the client. Finding 6. Serosanguineous drainage transitions to clear golden bile by day 3. This is expected, document only. A normal pattern is, initially a bit of bloody or serosanguineous fluid, then brown-green bile, then a lighter yellow-golden bile as healing progresses. We document the change as an expected sign of recovery. So in summary, expected, document, findings 1 and 6. Requires nursing intervention, findings 2 and 5. Notify provider, findings 3 and 4. Now, let's pull out the NCLEX-style alerts from this question. A few core T-tube safety rules. Keep the drainage bag below the level of the abdomen at all times. Never clamp or irrigate a T-tube without a specific order. Record color, consistency, and amount at regular intervals, often every 8 hours. Report sudden cessation of drainage that cannot be corrected. Bright red drainage, foul odor, signs of infection, or excessive output to the provider. Here's the key takeaway. Post-op biliary drainage questions on the NCLEX are really testing whether you can sort findings into normal, just document, fixable by the nurse, and danger, call the provider. If the finding suggests bleeding, significant fluid loss, or backflow into the biliary tree, it deserves immediate attention. Being able to quickly classify these cues in your mind protects your client and earns you points on the exam. Let's move on to the next question and keep sharpening your postoperative safety judgment. Question 18. We're now looking at a client who just had a Billroth 2 gastrojejunostomy, a major gastric surgery that requires very strict postoperative precautions. The nurse reviews the first day postoperative orders, and you'll listen closely because one of these orders is unsafe and must be clarified before performing it. Here are the orders you're evaluating. Encourage leg exercises every hour while awake. Assist with early ambulation as tolerated. Irrigate the nasogastric tube every 4 hours with 30 milliliters of normal saline. Reinforce coughing and deep breathing every 2 hours. Monitor NG drainage color and amount every 8 hours. Take a few seconds and identify the one that poses a danger to the client. The order we must highlight and absolutely clarify is irrigate the nasogastric tube every 4 hours with 30 milliliters of normal saline. Let's break down why. Let's look at the reasoning behind the correct choice. After a Billroth 2 procedure, the surgical connection between the stomach and the jejunum is fragile. Any manipulation of the NG tube, irrigating it, repositioning it, or advancing it can tear the anastomosis, cause bleeding, or even lead to perforation. The NG tube must stay exactly where the surgeon placed it. If it clogs or stops draining, the nurse does not irrigate it. The correct action is to notify the surgeon immediately, because only the surgeon decides how to manage that tube after gastric surgery. This is a classic NCLEX safety rule. Do not irrigate an NG tube after gastric surgery unless the surgeon personally orders it. Now let's look at why the other orders are safe. Leg exercises and early ambulation, excellent for preventing DVTs and promoting circulation. Coughing and deep breathing, essential for preventing atelectasis in any abdominal surgery client. Monitoring NG drainage, critical for detecting bleeding, obstruction, or leaks, absolutely appropriate. These orders support recovery. Only the irrigation order puts the client at risk. NCLEX alert: never irrigate, reposition, or reinsert an NG tube after gastric or esophageal surgery unless the surgeon explicitly orders it. If the NG drainage suddenly stops, turns bright red, or the client becomes distended, that is a provider notification, not a grab the syringe moment. Key takeaway: your next step after identifying an unsafe order is simple. Pause, protect the client, and clarify the prescription. If an order threatens the surgical site, you don't perform it, even if it appears on the chart. Let's keep going. The next question builds even more on your procedural safety judgment. Question 19. Dumping syndrome prevention. We're working with a client who's recovering from a gastrectomy, specifically a Billroth 2 procedure, and now the nurse is providing discharge teaching on how to prevent dumping syndrome. Let's look at the options and think through each one. Option 1. Ambulate immediately following each meal. Option 2. Limit fluids taken with meals. Option 3. Eat cakes and pastries only if they are homemade. Option 4. Eat 3 large meals per day instead of small frequent meals. Take a moment and decide which instruction best prevents dumping syndrome. The correct answer here is option 2. Limit fluids taken with meals. Now, let's break down why this is the safest and most effective teaching point. Let's look at the reasoning behind the correct choice. Limiting fluids during meals slows the rate of gastric emptying. When a client drinks a lot with meals, the stomach contents move rapidly into the small intestine. This triggers a sudden shift of fluid into the bowel, causing the classic dumping syndrome symptoms: sweating, dizziness, palpitations, and that intense abdominal cramping. By reducing fluids during meals and drinking mostly between meals, we avoid those rapid shifts. And here's why the other options don't work. Option 1. Ambulating right after eating actually speeds up gastric emptying, making dumping syndrome worse. Option 3. Cakes and pastries, whether homemade or not, contain simple sugars that rapidly draw fluid into the intestine. Definitely not recommended. Option 4. 3 large meals overwhelm the stomach at once and empty too quickly. We want small, frequent meals to keep the volume steady and predictable. NCLEX alert. To prevent dumping syndrome after gastric surgery, remember these pillars: small, frequent meals, low carbohydrate intake, avoid simple sugars and milk, lie down for 15 to 30 minutes after eating. Fluids between meals, not with meals. Dumping syndrome is all about controlling volume and pace. Key takeaway: the goal is to slow the transit time from stomach to small intestine. Teaching the client to limit fluids with meals is one of the most effective ways to do that. Great work. Let's keep the flow going. We're ready for question 20. Question 20. Multiple choice question. We're now reviewing client teaching for a hiatal hernia, a condition where part of the stomach slides up through the diaphragm, making reflux much more likely. Your job is to identify the one action the client must avoid after meals. Here are the 4 options. Option 1. Lying recumbent following meals. Option 2. Eating small, frequent, bland meals. Option 3. Taking prescribed H2 receptor antagonist medication. Option 4. Sleeping with the head of the bed elevated on 6-inch blocks. Take a few seconds and think through which behavior makes reflux worse. The correct answer is option 1, lying recumbent following meals. Let's walk through the reasoning. Let's break down why this option is the one to avoid. Lying flat after eating allows stomach contents to slide directly into the esophagus through the weakened hiatus. This dramatically increases heartburn, regurgitation, and nighttime reflux. Clients with hiatal hernia should stay upright for 1 to 2 hours after meals and should sleep with the head of the bed elevated, never flat. Now let's see why the other options are appropriate. Option 2. Small, frequent, bland meals reduce gastric pressure. Excellent teaching. Option 3. H2 blockers decrease acid production. Appropriate and commonly prescribed. Option 4. Head of bed elevation reduces reflux during rest. Exactly what we want. Only lying recumbent after meals worsens the condition. For hiatal hernia and chronic reflux, remember, never lie flat after eating. Avoid large, fatty, or spicy meals. Skip alcohol, caffeine, chocolate, and tight clothing. Use small, frequent meals and elevate the head of the bed. Lifestyle modification is always the first-line approach before considering surgical repair. Key takeaway: positioning plays a huge role in reflux control. Staying upright after meals is one of the simplest and most effective interventions for managing a hiatal hernia. Great! Let's keep this momentum. We're ready to move into question 21. Question 21. Transverse colostomy. Identifying a critical postoperative finding. A client had a transverse colostomy created 24 hours ago for a bowel obstruction. The nurse is now assessing the stoma and surrounding skin to decide what is expected and what is an emergency. Which observation requires immediate notification of the primary healthcare provider? Here are your options. Option 1. Stoma appears beefy, red, and moist. Option 2. Purple discoloration of the stoma. Option 3. Mild skin irritation around the stoma. Option 4. Semiformed stool noted in the ostomy pouch. Take a moment and think. Which finding is not just abnormal, but threatens tissue survival? The correct answer is option 2, purple discoloration of the stoma. Let's look at the reasoning behind that choice. A stoma should normally look beefy, red, moist, and slightly edematous in the first few days after surgery. When the stoma turns dusky, bluish, or purple, that means blood flow is compromised. We call this ischemia. If ischemia continues, the stoma can become necrotic, and that is a surgical emergency. So, a purple stoma requires immediate provider notification, documentation of the color and findings, and close monitoring. Now let's briefly look at why the other options are not emergent. Option 1. Beefy, red, and moist. This is actually the ideal appearance of a healthy stoma. It indicates good perfusion. Option 3. Mild skin irritation around the stoma. Peristomal skin breakdown or irritation is common and needs nursing intervention, such as better pouch fitting, skin barrier products, or teaching, but it is not an emergency. Option 4. Semiformed stool in the pouch. For a transverse colostomy, semiformed stool is an expected type of output once bowel function returns. So only option 2 rises to the level of call the provider now. Here are a few NCLEX alerts tied to this topic. Stoma color is your quickest window into perfusion. Bright or beefy red equals normal, healthy blood flow. Pale equals possible anemia or early poor perfusion. Dusky, bluish, or purple equals ischemia and potential necrosis arrow emergency. Each shift, always assess color, moisture, protrusion, and peristomal skin. And here's your key takeaway. With any new ostomy, the stoma's color is a priority assessment, just like pulses in a limb after a cast. If the stoma looks purple, blue, or black, you don't just make a note, you act. That rapid recognition of perfusion threats is exactly the kind of safety-focused thinking the NCLEX is testing. Let's keep going and build on this with the next colostomy-related question. Question 22, multiple choice. A client is 2 days post-operative following the creation of a new colostomy. The nurse notes that malodorous flatus is being expelled from the stoma. Which interpretation by the nurse is correct? Here are your options. Option 1. This is a normal, expected event. Option 2. This indicates early signs of ischemic bowel. Option 3. The nasogastric tube should not yet be removed. Option 4. This suggests inadequate preoperative bowel preparation. Take a moment and think. What does passing gas from a new colostomy really tell you about bowel function? The correct answer is option 1. This is a normal, expected event. Let's look at the reasoning behind that choice. When a client begins to pass flatus from a new colostomy, it means that peristalsis is returning and the bowel is starting to function again. This usually occurs within 48 to 72 hours after surgery. So malodorous gas from the stoma at post-op day 2 is actually a good sign, not a complication. Now, let's see why the other options are incorrect. Option 2, early signs of ischemic bowel. In ischemia or obstruction, we would be worried about no flatus, no stool, increasing pain, and progressive abdominal distension, not active gas output. Option 3, the NG tube should not yet be removed. In reality, the return of bowel activity, especially flatus, is one of the signs that the GI tract is waking up and that the NG tube may soon be ready for removal, depending on the provider's assessment and orders. Option 4, inadequate preoperative bowel preparation. Bowel prep relates to how clean the bowel was before surgery. Post-op flatus has nothing to do with that. It reflects current motility, not prep quality. Let's pull an NCLEX-style alert from this concept. Passing flatus is often the first sign that peristalsis is returning after abdominal surgery. Stool output from a new colostomy typically begins within about 72 hours. By contrast, no flatus or stool beyond 3 to 5 days may signal paralytic ileus or obstruction and requires further evaluation. Key takeaway. When you see a question about a fresh colostomy and the client is passing gas from the stoma, think, good, the gut is waking up. Recognizing what is reassuring versus what is concerning in early post-op ostomy care is a subtle but powerful exam skill. All right, let's move on to the next question and continue building your post-operative GI judgment. Question 23. Ileostomy, immediate post-operative complication. We now have a client with severe Crohn's disease who has just undergone surgery for the creation of an ileostomy. In the immediate postoperative period, the nurse must be alert for the most common early complication. Here are the options. Option 1, folate deficiency. Option 2, malabsorption of fat. Option 3, intestinal obstruction. Option 4, fluid and electrolyte imbalance. Take a moment and think, which of these occurs early, within the first 24 to 48 hours, because of the nature of ileostomy output? The correct answer is option 4, fluid and electrolyte imbalance. Let's walk through why this is the priority. An ileostomy drains liquid, continuous output. This output contains large amounts of water, sodium, and potassium. Right after surgery, when the bowel is still adjusting, that output can be high volume, putting the client at significant risk for dehydration, hyponatremia, and hypokalemia. That's why strict intake and output monitoring, lab monitoring, and IV fluid replacement are essential in the immediate postoperative phase. Now let's look at why the other choices are not immediate complications. Option 1, folate deficiency. This develops later due to the loss of absorption in the terminal ileum. Option 2, fat malabsorption. Also a long-term issue related to decreased bile salt recycling. Option 3, intestinal obstruction. This can occur, but is less common in the early stage. It typically happens later due to adhesions or stenosis. Early postoperative, the biggest threat is fluid and electrolyte loss. NCLEX alert. Ileostomy output is watery, high volume, and rich in electrolytes. Watch for dry mucous membranes, low urine output, tachycardia, dizziness, muscle cramps, output greater than 1,200 milliliters per day, or symptoms of dehydration should be reported immediately. Key takeaway. For new ileostomies, think fluid loss first. Early identification of electrolyte imbalance can prevent serious complications, and this is exactly the level of clinical judgment the NCLEX wants you to demonstrate. Great job. Let's move on to the next question and keep building your GI postoperative expertise. Question 24. Dumping syndrome. Early versus late manifestations. Item type, matrix, grid. The nurse is teaching a client recovering from a gastrectomy about the difference between early dumping syndrome and late dumping syndrome. Early dumping happens about 5 to 30 minutes after eating. Late dumping happens about 1 to 3 hours after eating. You're given a list of symptoms, and your job is to decide whether each one belongs to early or late dumping. Here are the symptoms: sweating and pallor, dizziness and tachycardia, abdominal cramping and diarrhea, weakness and tremors, hunger and irritability, confusion or faintness from hypoglycemia. Take a moment and mentally sort each one into early or late. Now, let's check the correct classification. Early dumping syndrome, 5 to 30 minutes after eating. Sweating and pallor, dizziness and tachycardia, abdominal cramping and diarrhea. Late dumping syndrome, 1 to 3 hours after eating. Weakness and tremors, hunger and irritability, confusion or faintness from hypoglycemia. Let's connect this to the underlying physiology. Early dumping is all about a rapid fluid shift. Because the stomach empties too fast, a hyperosmolar bolus suddenly arrives in the small intestine. Fluid moves from the bloodstream into the gut lumen, and the client experiences vasomotor symptoms like sweating, pallor, dizziness, and tachycardia, gastrointestinal symptoms like cramping and diarrhea. So when you see sweating, pallor, dizziness, tachycardia, and cramping shortly after a meal, think early dumping, fluid shift, and vasomotor response. Late dumping is a hypoglycemia problem. After that rapid emptying, blood sugar spikes, and then the body releases a big burst of insulin. 1 to 3 hours later, the client's blood sugar drops too low, reactive hypoglycemia. That's when you see weakness and tremors, hunger and irritability, confusion or faintness. So when a client says, "I feel shaky, weak, and starving a couple of hours after I eat," you should be thinking late dumping, postprandial hypoglycemia. NCLEX alert. Timing is everything. Minutes after a meal, fluid shifts, vasomotor and GI symptoms, early dumping. 1 to 3 hours after a meal, insulin surge, low blood sugar, late dumping. Prevention strategies you should know. Cold. Eat small, frequent meals. Limit fluids with meals. Take most fluids between meals. Choose high protein, moderate fat, low carbohydrate meals. Rest or lie down 15 to 30 minutes after eating to slow gastric emptying. Key takeaway: if the symptoms show up right after eating, think fluid shift and vasomotor, early. If they show up an hour or two later, think insulin overshoot and hypoglycemia, late. Sorting symptoms by timing plus mechanism is exactly the kind of matrix thinking the NCLEX expects from you. Question 25. Irritable bowel syndrome, IBS, stepwise nursing management. We're looking at a 35-year-old client diagnosed with irritable bowel syndrome, or IBS, after months of intermittent cramping, bloating, and alternating diarrhea and constipation. The nurse is creating a stepwise plan of care, starting with the least invasive, non-pharmacologic strategies, and only moving to medications if needed. You're asked to place the following nursing actions in the correct order of implementation. Use all options. Here are the options. Option A. Assess and document the client's typical dietary intake, bowel pattern, and stress triggers. Option B. Provide ongoing teaching about self-monitoring, journaling symptoms, and adjusting lifestyle habits to maintain symptom control. Option C. Introduce stress reduction strategies such as relaxation breathing, yoga, or cognitive behavioral therapy. Option D. Collaborate with the provider about pharmacologic therapy if symptoms persist, for example, antispasmodics, bulk-forming agents, or antidiarrheals. Option E. Initiate dietary modifications. Increase fiber gradually and avoid gas-producing or trigger foods such as caffeine, fatty foods, dairy, and sorbitol. Take a few seconds and think. If you were following the nursing process and a stepwise approach, what would you do first, and what would come next? The correct order is A, E, C, D, B. Let's walk through why this sequence makes sense. Step 1. Assess and document patterns first. We always start with assessment. You need to know, what does the client eat? When do symptoms get worse? What are the bowel habits like? Are there clear stress triggers or specific foods that consistently lead to cramping or diarrhea? Without this baseline information, any plan you make is just guessing. Step 2. Initiate dietary modifications. Once you know the pattern, the first-line intervention for IBS is dietary change. That means increasing fiber gradually to avoid making gas and bloating worse, and avoiding trigger foods, caffeine, fatty or fried foods, certain dairy products, gas-forming foods, and sugar alcohols like sorbitol. Diet and fluid management are always your first big lever. Step 3. Introduce stress reduction strategies. IBS is highly stress responsive. The brain-gut connection is strong here, so we teach relaxation breathing, yoga, mindfulness techniques, or even referral for cognitive behavioral therapy if appropriate. Reducing autonomic arousal lowers bowel hypersensitivity and can dramatically reduce symptoms. Step 4. Collaborate about pharmacologic therapy if symptoms persist. Only after diet and stress interventions have been tried and are not enough, we move to medications in collaboration with the provider. These may include antispasmodics like dicyclamine for cramping, bulk-forming agents like psyllium for stool regulation, antidiarrheals like loperamide for loose stools, sometimes low-dose antidepressants for visceral hypersensitivity. This is escalation, not the starting point. Step 5. Provide ongoing teaching about self-monitoring and lifestyle adjustment. Finally, we reinforce long-term self-management. Keeping a symptom and food journal, recognizing early warning signs, adjusting diet and stress strategies as life circumstances change, and understanding when to call the provider. This step cements the client's ability to manage IBS over time, not just in the hospital. Here's an NCLEX-style way to frame this. IBS is a functional disorder, meaning no structural damage, but very real symptoms. Your priority is to assess, adjust diet, manage stress, add meds if needed, reinforce self-management. If a question jumps straight to medications without assessment or lifestyle changes, that should raise a red flag in your mind. Key takeaway. For chronic conditions like IBS, the NCLEX wants to see stepwise, holistic thinking. Not just what drug do we give, but what can we change about diet, stress, and daily routines first, and how do we empower the client to stay in control? That's the clinical judgment that separates guessing from real nursing reasoning. Great job finishing the procedures and diagnostics section. Now we move into section 3, GI Pharmacology. In this part, you'll apply the same clinical reasoning, but through a medication lens, how the drug works, what to expect, what's dangerous, and what teaching the NCLEX focuses on. We'll keep the flow simple. Read the scenario, think through the options, then I'll guide you through the correct reasoning, the red flags, and the key takeaways. Let's get started with GI Pharmacology, Q26 to Q32. Infliximab, evaluating effectiveness. Question 26. We're looking at infliximab, one of the major biologic therapies used for severe Crohn's disease. The goal here is to evaluate how we know the medication is actually working. Let's walk through the options. Option 1. Monitoring the leukocyte count after the infusion. That mainly tells us about possible infection or bone marrow effects, not whether the drug is improving symptoms. Option 2. Checking the frequency and consistency of bowel movements. This is the correct indicator. Crohn's flare-ups are all about inflammation, diarrhea, abdominal pain. If infliximab is effective, stool frequency goes down, stool consistency improves, and the client reports less cramping. This directly reflects decreased mucosal inflammation, which is the intended pharmacologic effect. Option 3. Checking liver enzymes before and after treatment. That's safety monitoring, not an effectiveness measure. Option 4. Performing a HEMA test on gastric aspirate. Unrelated to Crohn's disease and doesn't tell us anything about whether the medication is helping. So the best indicator of therapeutic response is option 2. Now let's reinforce the key safety points. Infliximab suppresses immune activity. That means higher infection risk, so always screen for tuberculosis before starting the medication, and teach the client to report fever, sore throat, cough, or unusual fatigue immediately. Key takeaway? Effectiveness is measured by improved stool pattern. Safety is monitored through infection surveillance. Let's move on to the next pharmacology question. Question 27. Loperamide, antidiarrheal, indication and intended effect. A client with gastroenteritis has an as-needed prescription for loperamide hydrochloride. The nurse needs to determine both the correct indication and the expected therapeutic effect of this medication. Let's go through the drop-down statements one at a time. Statement 1. Loperamide is indicated for the treatment of blank 1. Here are the options: constipation, abdominal pain, diarrhea, vomiting. Take a moment to think about which one is correct. The correct option is diarrhea. Statement 2. The desired therapeutic effect is blank 2. Options: fewer stools, more bowel movements, increased appetite, less abdominal gas. Take a moment here as well. The correct answer is fewer stools. Rationale: loperamide slows intestinal motility, giving the bowel more time to absorb water. Because of this, the frequency of stools decreases and stool consistency improves. It is used for acute or chronic diarrhea, and it can also reduce output in clients with an ileostomy. It is not appropriate for constipation, abdominal pain alone, or vomiting, and it should not be used for infectious diarrhea. NCLEX alert: do not give loperamide when diarrhea is bloody, associated with fever, or suspected to be caused by C. diff or another infectious organism. Slowing the bowel in those cases can trap toxins and worsen illness. Always evaluate hydration and electrolyte status before and after giving antidiarrheals. Key takeaway: loperamide is indicated for non-infectious diarrhea, and the expected therapeutic outcome is fewer stools with improved consistency. Let's continue to the next medication and keep building strong GI pharmacology reasoning. Question 28. Pancrealipase, pancreatic enzyme replacement. Expected benefit. A client with chronic pancreatitis has been prescribed pancrealipase as part of long-term therapy. Your goal as the nurse is to evaluate whether the medication is actually working. Let's look at the options: weight loss, relief of heartburn, reduction of steatorrhea, absence of abdominal pain. Take a moment to think through which one best reflects medication effectiveness. The correct answer is option 3, reduction of steatorrhea. Let's look at the rationale behind the correct answer. Pancrealipase contains digestive enzymes, lipase, protease, and amylase. Clients with chronic pancreatitis don't produce enough enzymes naturally, so they develop steatorrhea, fatty, pale, foul-smelling stools caused by malabsorption. When pancrealipase is effective, the bowel movements become more formed, less oily, and less frequent. Nutrient absorption improves, weight stabilizes, and the client begins to regain nutritional balance. That's why reduced steatorrhea is the strongest clinical indicator of success. Now let's look at why the other options are incorrect. Option 1, weight loss. If the client is still losing weight, the medication is not working. That means malabsorption continues. Option 2, relief of heartburn. Heartburn is not related to pancreatic enzyme function. This finding tells us nothing about pancrealipase effectiveness. Option 4, absence of abdominal pain. Pain may improve overall, but it is not the primary marker of how well the enzyme therapy is working. NCLEX alert: for pancrealipase, safe administration matters. Give with meals or snacks, not before and not after. Do not crush enteric-coated tablets. Capsules should be swallowed whole. Monitor for weight stabilization, improve nutritional markers, and decrease steatorrhea. If stools remain fatty or the client continues losing weight, dosing or timing may need adjustment. Key takeaway: pancrealipase is effective when steatorrhea decreases and nutrient absorption improves. Always link medication mechanism, expected clinical outcome. Let's keep going with GI pharmacology and build on this momentum. All right, question 29. Cimetidine, H2 blocker. CNS effects in older adults. Multiple choice. An older adult with peptic ulcer disease has been taking cimetidine for several weeks. Because this medication crosses the blood-brain barrier, older adults are at greater risk for central nervous system effects. Your task is to identify the most common CNS effect you should watch for. Let's look at the options. Option 1, tremors. Option 2, dizziness. Option 3, confusion. Option 4, hallucinations. Take a moment. Think about which effect older adults experience most often. The correct answer is option 3, confusion. Let's look at the rationale behind the correct answer. Cimetidine is an H2 receptor antagonist that can cross into the central nervous system. In older adults, especially those with impaired renal or hepatic function, this often results in reversible confusion or disorientation. It's the most frequently observed CNS effect with this drug in this population. Now let's look at why the other options are incorrect. Tremors, not typical of cimetidine. Tremors are more commonly associated with dopamine-blocking medications like metoclopramide. Dizziness, possible but less common than confusion. Hallucinations. These are rare and usually associated with very high doses or severe toxicity. NCLEX alert. When giving cimetidine to older adults, monitor closely for confusion, agitation, restlessness, or lethargy. Reduce dosing in renal or hepatic impairment. Avoid taking antacids within 1 hour of cimetidine. They reduce absorption. This drug is effective, but it can cause unexpected neuro changes in older clients. Key takeaway. With cimetidine, the most frequent CNS effect in older adults is confusion. Always think elderly plus H2 blocker equals mental status changes. Let's move on. All right, question 30. H. pylori triple therapy. Drug, mechanism, duration matrix, grid item. A client with peptic ulcer disease tests positive for Helicobacter pylori. They are prescribed the classic triple therapy regimen, clarithromycin, amoxicillin, and esomeprazole, and discussed by the nurse with client. Your job is to determine which statements about these medications are correct and which ones show a misunderstanding. Let's go statement by statement. Matrix statements. I will read each statement, give you a moment to think, then we'll mark it correct or incorrect, followed by the teaching behind it. Statement 1. Clarithromycin is an antibiotic that kills H. pylori by inhibiting bacterial protein synthesis. Think. This statement is correct. Clarithromycin is a macrolide antibiotic. It blocks bacterial protein synthesis, weakening H. pylori and helping eradicate the infection. Statement 2. Amoxicillin destroys H. pylori by weakening the bacterial cell wall. This is also correct. Amoxicillin is a beta-lactam antibiotic, and it disrupts cell wall formation, another core part of H. pylori eradication. Statement 3. Esomeprazole increases gastric acid secretion to help kill H. pylori. This statement is incorrect. Esomeprazole is a proton pump inhibitor. It suppresses gastric acid, does not increase it. Lowering acid promotes ulcer healing and helps the antibiotics work better. Statement 4. Triple therapy antibiotics are taken for 10 to 14 days, while the PPI continues for 4 to 8 weeks. This statement is correct. That is the standard treatment timeline. 2 antibiotics for 10 to 14 days, and the PPI for a much longer period to support gastric healing. Statement 5. This regimen should be taken only when ulcer pain occurs. This is incorrect. Triple therapy must be taken as prescribed every day, not just when symptoms appear. Stopping or skipping doses leads to resistance and ulcer recurrence. NCLEX alert. Triple therapy equals 2 antibiotics plus 1 PPI. It must be taken consistently even if symptoms improve early. Watch for red flags like persistent diarrhea or black stools, which can signal C. difficile infection. Key takeaway. H. pylori management requires mechanism-based precision. The antibiotics kill the organism, the PPI reduces acid so the stomach can heal, and the regimen must be followed for the full duration. Let's move on. All right, moving into question 31. Omeprazole versus sucralfate. Correct administration timing, multiple choice item. We're reviewing medication teaching for a client-prescribed omeprazole, a proton pump inhibitor, and sucralfate, a mucosal protectant. Timing matters here because both medications depend on the stomach's environment to work properly. Let's look at the options. Options 1. Take both medications together with breakfast each morning. 2. Take omeprazole before breakfast and sucralfate 30 minutes later on an empty stomach. 3. Take sucralfate at bedtime and omeprazole only if symptoms occur. 4. Take sucralfate with food and omeprazole immediately after meals. Take a moment to think about which sequence gives both drugs the best chance to work. Pause. Correct answer, option 2. Take omeprazole before breakfast and sucralfate 30 minutes later on an empty stomach. Let's look at the reasoning, why option 2 is correct. Omeprazole needs to be taken before meals, ideally 30 to 60 minutes before breakfast, so it can block active acid pumps. Sucralfate needs an acidic, empty stomach to form its protective barrier. Separating them by at least 30 minutes ensures optimal absorption for both. Now, why the other options are incorrect. Option 1. Both medications together. This is ineffective. Sucralfate can bind to omeprazole and prevent proper absorption. Option 3. PPI only if symptoms occur. Omeprazole is not a PRN medication. It must be taken daily before meals to reduce acid secretion. Option 4. Sucralfate with food. Sucralfate must be taken before meals, not with food, or it won't adhere to ulcer sites properly. NCLEX alert. Remember the timing rule. PPI first, sucralfate second. Keep them separated to avoid absorption interference. Never give sucralfate simultaneously with antacids or PPIs. Key takeaway. Match the timing to the mechanism. Suppress acid before eating, then coat the ulcer on an empty stomach. That's how both medications deliver maximum benefit. Let's move on to the next question. You're doing great. All right, moving into question 32. Antiemetic pharmacology. Safe and unsafe understanding. Select all that apply. This one brings together several different antiemetic medications, ondansetron, promethazine, metoclopramide, and scopolamine, and asks you to evaluate which client statements show correct understanding. Let's look carefully at each option. 1. My ondansetron will help control nausea and vomiting after chemotherapy. 2. If I feel sleepy after taking promethazine, I can still drive as long as I feel alert enough. 3. I will change positions slowly while taking metoclopramide to prevent dizziness. 4. If I have facial twitching or involuntary movements while taking metoclopramide, it means the medicine is working well. 5. I can use scopolamine patches to prevent motion sickness, and I'll replace the patch every 72 hours. 6. If my nausea continues, I'll double my dose of ondansetron for faster relief. Take a moment to think about which statements are correct and safe, and which ones reveal dangerous misunderstandings. Correct answers: options 1, 3, and 5. Let's walk through why these are correct. Option 1, correct. Ondansetron is a serotonin receptor blocker widely used for chemotherapy-related and postoperative nausea. This is an accurate understanding of its purpose. Option 3, correct. Metoclopramide can cause orthostatic hypotension, so rising slowly is a smart and safe practice. This statement shows proper safety awareness. Option 5, correct. Scopolamine patches prevent motion sickness and are correctly replaced every 72 hours. Clients must wash their hands after handling the patch to avoid accidental eye contact and blurred vision. Now, let's break down the incorrect statements. Option 2, incorrect. Promethazine causes significant sedation and respiratory depression. Clients should never drive or operate machinery while taking it, even if they feel alert. Option 4, incorrect and dangerous. Facial twitching, lip smacking, or involuntary movements while on metoclopramide are extrapyramidal symptoms. These are serious adverse reactions, not signs that the medication is working. They require immediate provider notification. Option 6, incorrect. Doubling ondansetron is unsafe. High doses increase the risk of QT prolongation and arrhythmias. Clients should never self-adjust antiemetic dosing. NCLEX alert: promethazine, sedation and respiratory depression. Metoclopramide, watch for EPS and tardive dyskinesia. Ondansetron, QT prolongation risk. Scopolamine, anticholinergic effects. Replace patch every 72 hours. Key takeaway: safe antiemetic use depends on recognizing which effects are expected, which ones are dangerous, and when clients need more teaching to protect themselves. Great work staying sharp on these high-yield pharmacology details. Before we wrap up, here's your quick NCLEX challenge. Imagine a client with a history of peptic ulcer disease suddenly develops sharp abdominal pain and a rigid, board-like abdomen. What's your very first action? Think. You notify the provider immediately. That combination of pain and rigidity signals a possible perforation, a red flag emergency that requires rapid intervention. Always think pain plus rigid abdomen equals perforation equals call the provider. Quick summary: what you mastered today. In this GI masterclass, you strengthened every high-yield concept you need for the exam. How to spot life-threatening complications like peritonitis, bowel obstruction, and dumping syndrome. How to separate normal versus abnormal postoperative findings. How to evaluate whether GI medications are working or failing, from infliximab to pancreolipase. How to identify dangerous adverse effects like cimetidine-induced confusion or metoclopramide-related EPS. And how to apply full NGN logic using highlight, drop-down, matrix, SAT, and ordered response items. Every question trains your clinical judgment, not just recall. Stay exam smart with NCLEX Review Pro. If this session helped you think more like a nurse, subscribe, share it with your study group, and keep sharpening that NCLEX mindset. Remember, the exam doesn't ask, "What do you know?" It asks, "What will you do?" Stay consistent, keep practicing clinical judgment, and I'll see you in the next video. NCLEX Review Pro. Learn smart, think safe, pass confidently.